Hello everyone, I'm Dr. Jolsna and welcome to my channel ProsthoHub. So today we are going to discuss the second session of implant loading protocols. So in the previous session we have discussed the introduction, definitions, the various protocols of implant loading, and in that we have discussed in detail about the Brennemark's two-stage protocol and also about the progressive loading and the elements in it. So in this session we'll be discussing the immediate loading protocol in detail. So before beginning, I request everyone to please do like and share my videos if you're finding them useful. And if you're new to this channel ProsthoHub, please do subscribe and support me. If you have any queries, suggestions, any topic that needs to be discussed or any feedback, please do comment below this video or you can mail me at this mail ID. So let us see the contents of immediate implant loading protocol. So the contents include definition, indications, contraindications, advantages, disadvantages, factors that determine immediate loading, and guidelines for immediate loading. So immediate loading, you can expect it as a 7-mark short note, or it can come as a sub-question of the loading protocols, which can be asked for 75 marks. So what is immediate implant loading? This can be briefly defined as loading of a dental implant immediately or few hours after being placed. And this approach has been called a one-stage or a non-submerged implant procedure because it eliminates the second stage, implant uncovering surgery. So actually here we load the implant with a provisional restoration at the same appointment or shortly thereafter. So the placement of a temporary restoration on the day of implant surgery may offer aesthetic, psychological and functional advantages as compared with the use of a provisional removable prosthesis. So what is immediate occlusal loading? An implant is placed with adequate primary stability and its corresponding restoration has full centric occlusion in maximum intercuspation and must be placed within 48 hours post-surgery. Whereas immediate non-occlusal loading, that is an implant is placed with adequate primary stability but is not in functional occlusion, and this is specially for aesthetic purpose, frequently in single tooth or short span application, and the patient here will have a benefit of aesthetic along with a psychological benefit during the implant therapy, particularly when a provisional removable prosthesis is undesirable during the healing period. Let us see the indications. So there should be adequate bone quality and sufficient bone height of approximately 12 mm for a minimum length of 10 mm implant and sufficient bone width, that is approx 6 mm, and also ability to achieve an adequate anterior-posterior spread between the implants. Coming to contraindications, poor systemic health, severe parafunctional habits like patients who are severe bruxers, and bone that is of poor quality type 4 bone, and bone height that is less than 10 mm and bone width less than 6 mm, and cases where there is inability to achieve an adequate anterior-posterior spread. Coming to advantages, so immediate loading eliminates the need for and maintenance of a removable provisional prosthesis. So that will give an emotional benefit for a patient that is scheduled to rendered edentulous. It improves bone healing and facilitates soft tissue shaping, and also it eliminates premature implant exposure that can happen with wearing of a removable prosthesis during the healing period. So these are the advantages of immediate implant loading. Now coming to disadvantages, so immediate loading cannot be applied to every implant patient. So there are more chances of failures post-op, and also the peri-implant bone reaction is highest after surgical trauma due to this immediate loading, and it requires more chairside time and patient cooperation, and compared to delayed loading there is more bone loss in immediate loading. Next, coming to the factors that determine immediate loading. So these factors can be classified as implant related factors and patient related factors. So let us see them in detail. So the implant related factors include the factors that can increase the surface area, that is implant number, implant size, implant body design and implant surface condition, and factors that can decrease the force, that is occlusal load direction, the implant position, the cantilever forces and occlusal contacts, and then the patient related factors that include patient habits as well as diet and oral hygiene. So one goal for an immediate loaded implant prosthesis system is to decrease the risk of occlusal overload and its resultant increase in the remodeling rate of bone. So one method to decrease this microstrain and to improve the remodeling is to provide condition that increases functional surface area to the implant bone interface. So the first factor is implant number. So implant number increases the functional surface area, and also it increases the success rate, because even if one or two implant fail, it will not affect the prognosis. So actually there are two protocols in immediate implant loading. In the first protocol, it involves placing more implants than the usual treatment plan for a conventional healing period. So among these implants, only the selected implants are loaded immediately, that is with the transitional prosthesis. The remaining ones are left submerged for regular healing period. So even if one or two implants fail or the immediately loaded implants fail, it does not affect the prognosis of the prosthesis. And if any of the implants survive, they are also used in the final restoration. So that is first protocol. Whereas the second protocol includes immediate occlusal loading of all the initially loaded implants, and these implants are splinted together. So splinting will decrease the stress on all the developing interfaces, and also it increases stability, retention and strength of the transitional prosthesis during the initial healing phase. So these are the two protocols, first and second protocol of immediate implant loading. Next, the increasing implant number increases the retention of the prosthesis, and also it reduces the number of pondings. So decrease in number of ponding will decrease the risk of fracture of the transitional prosthesis, which may be a source of overload to the remaining implants. Now if you consider maxilla and mandible, often more implants are used in maxilla, that is 8 to 10, compared to that of mandible, where we place 5 to 9 implants. So this is because the maxilla is less dense, and also there is increased direction of force found in maxilla. Second factor is implant size. So the surface area of implant support can be increased by size of the implant. So the size can be either in length or increase in width. So each 3 mm increase in length can improve the surface area support by more than 20%. But the problem with increasing length is that most of the stresses to an implant bone interface are concentrated at the crestal bone. But by increasing the implant length, it does very little to decrease the stress that occurs at the crestal bone. So we have to increase the width. But increasing length can be useful in softer bones because it increases the initial stability of the bone implant interface. So increasing length is relevant in immediate implant loading, especially in softer bones. Whereas functional surface area of each implant support system is related primarily to the width and design of the implant. So bone augmentation in width can be indicated in order to increase the implant diameter where forces are greater, like in cases of moderate to severe parafunction. So increasing the width is beneficial at the crest of the ridge than increasing the length of the implant. Coming to the next factor, that is implant body design. So implant body design should be more specific for immediate loading because the implants require maximum stability at the time of loading, and the bone does not have time to grow into the recesses or undercuts that is present in the design or attached to a surface condition before the application of occlusal load. For example, a press fit implant with a cylinder design, it does not have bone integration on the day of implant placement, and so it is least indicated for immediate loading. And for a threaded implants, it allows bone to be present in the depth of the threads from the day of insertion, and so the functional surface area is greater during the immediate loading format. So a threaded implant design is more beneficial than that of press fit because for immediate loading protocol, their design features do not require integration to resist loads, and also they have greater surface area to resist occlusal forces. And the number, spacing and orientation of the thread also affect the amount of area that is available to resist the forces during immediate loading. So greater the number of threads, greater is the functional surface area at the time of immediate loading. Now considering the depth of the thread. So greater the thread depth, greater is the surface area. So when the depth of these threads are increased, the surface area also increases, and also the greater is the initial fixation of the implant. So this is also beneficial for immediate implant loading. Now the thread geometry also may affect the strength of early osseointegration and the bone implant interface. So square threads, they show better resistance to torque than the V-shaped or reverse buttress design. So those who want to know in detail about the implant design and the thread geometry, please do comment below this video and I'll try to make a separate session on that. If you compare a tapered design to that of a parallel walled implant of same length, width and thread number, the tapered implant has got less overall surface area and they do not engage the bone physically as nicely as parallel, so it reduces the initial fixation. Also, it has got less thread depth near the apical portion of the implant, and this also reduces the surface area and decreases initial fixation. So, some studies have demonstrated that a tapered threaded implant design result in greater initial stability compared to that of cylindered implant designs, especially when the osteotomy site is compressed during implant insertion. So this feature is beneficial for lower density bone types. That is, a tapered threaded implant design has got greater initial stability compared to that of cylindered implant designs. Next is implant surface condition, which is the last factor under increasing the implant surface area. So implant surface conditions may affect the rate of bone contact, the lamellar bone formation and percentage of bone contact. So any surface condition that allows bone formation in greatest percentage, a higher bone implant contact with high mineralization rate and fastest lamellar bone formation will be of benefit in immediate loading. So such example is the hydroxyapatite coating, which is shown to have these properties along with a reduced rate of bone remodeling during occlusal loading. Hence, if the bone is not of ideal density such as a D4 bone, for immediate loading, hydroxyapatite may decrease the risk of overload. Next is decreased force condition. So, forces can be evaluated by their magnitude, duration, direction and type. And we should be careful to reduce the condition that magnifies the noxious effects of these forces. So, under decreased force conditions comes the occlusal load direction, the implant position, the occlusal contacts and cantilever forces. So the first one is occlusal load direction. So the occlusal load direction affect the remodeling rate. An axial load to an implant body maintains more lamellar bone and has got lower remodeling rate when compared with an implant of an offset load. And also a crown height can also become a vertical cantilever when angled forces or cantilever are placed on a prosthesis. So there should be no posterior cantilevers in the immediate load transitional restoration, and the angle of the load to the implant body should be along the long axis, especially when the crown height is greater than normal. Also, flat occlusal planes can be given in the posterior region. This also decreases the risk of angled loads to the implant body. So how an increased crown height acts as a vertical cantilever, this we have already discussed in our implant occlusion session. Next is the most important factor in immediate loading of completely edentulous patient, that is the implant position. So a cross arch splinding is a very effective design in order to reduce stress to the entire implant support system. So it is especially advantageous for the immediate load transitional processes, that is a completely edentulous patient. Now the cross arch splinding in mandible has been a topic of debate because of the flexion and torsion that occurs distal to the mental foramen. But acrylic that is being used in the transitional processes and the length of the span that is being flexible is enough to minimize these concerns. So mandible can be divided into three sections around the arch, that is the canine to canine area and bilateral posterior sections. So splinding is mainly to distribute the stress and to reduce the occlusal overload. Now, if you consider the maxilla, it requires more implant support than mandible. This is because the bone is less dense here and the direction of force is outside of arch in all excursive movements. So, the maxilla can be divided into minimum four sections, that is the bilateral canine regions and the bilateral posteriors. Now, if the force factors are high, then the incisor region can also be added into the standard force section. So, the maxilla consists of minimum 5 sections, that is the incisor region, the bilateral canines and the bilateral posteriors. And at least one implant should be inserted into each maxillary section and splinted together during immediate loading. Next is the cantilever force. So a cantilever on a prosthesis increases the moment loads to the implant bone interface, and cantilevers have been reported to increase the crestal bone loss, increase the abutment screw loosening, increase implant body fracture, and also increases the risk of implant failure. Therefore, an immediately loaded transitional prosthesis should not have a posterior cantilever because it is usually not in an aesthetic zone, and also the bite forces are greater in the posterior segments of the mouth. So we have already said immediately loaded transitional prosthesis should not have a posterior cantilever. Now it is also said that a partially uncemented restoration can also result in a cantilever along the remaining implants. So a definitive cement should be used for transitional restoration in order to decrease the risk of such partially retained conditions. Now, next is the occlusal contact, which is the final factor in decreasing the force. So here the amount of force to the prosthesis can be dramatically decreased in partially edentulous patient by eliminating any occlusal contact on the restoration. So as you can see in this picture, the first picture, that's a partially edentulous patient with an immediately loaded transitional restoration, splinting implants in the canine to the second premolar region. So here there is no occlusal contact that is provided, whereas this is the final 3-unit restoration after 4 months of initial healing, and here it has got full occlusal contact. So if you don't give occlusal contact in the initial phase, the amount of force is dramatically decreased and occlusal contacts can be given in the final restoration. Next, let us see the patient factors, that is the habits, diet and oral hygiene. So under habits, the parafunctions like bruxism and clenching, they represent significant force factors. This is because of the magnitude of forces increased and duration of forces increased, and the direction of force, it is more horizontal than axial to the implants, that is with a greater shear component. So parafunction poses a greater risk for immediate implant loading. The parafunctional loads also increases the risk of abutment screw loosening, unretained prostheses and fracture of transitional restoration that is used for immediate loading. So in the picture you can see that the transitional prosthesis has fractured into several pieces because of bruxism. And if any of these complications, that is any of abutment screw loosening or unretained prosthesis or transitional restoration fracture occurs, then the remaining implants that are loaded are also more likely to fail. The last factor is the diet and oral hygiene. So diet has been known to break or loosen a transitional prosthesis in traditional prosthetics. So if the immediate loaded prosthesis becomes partially uncemented or fractures, then the remaining implants also are at increased risk of overload failure. Therefore, the diet of the patient should be limited to only soft foods during the immediate load process. Next, the hygiene procedure usually consists of a regimen of chlorhexidine rinses twice daily, beginning immediately. And also the surgical site may be brushed with a very soft toothbrush, also called as the toothed type sponge applicator, usually 7 days after the implant placement. And then the use of water pick should be avoided to prevent the bacterial penetration of the surgical site. Flossing can be accomplished several weeks post surgery. And after 2 weeks, that is after the initial soft tissue healing, patient can assume a normal diet, but caution not to function directly on the immediately placed provisional for another 4 weeks. Thus, we have completed discussing the implant related as well as the patient related factors that determine immediate occlusal loading. And next is the immediate loading procedures for fixed prostheses. So two different options are available for this. That is the immediate occlusal loading for a completely edentulous patient desiring a fixed prosthesis. That is, the first option is loading the implant the same day as the surgery, whereas the second option is to place the implants and make an impression at surgery, and then at suture removal appointment, that is 7 to 12 days later, the dentist delivers the transitional fixed prosthesis. So these are the two options that is available for immediate loading for a fixed prosthesis. So this is an image that demonstrates the difference between the two-stage delayed loading protocol and the immediate loading protocol. As you can see here, in the two-stage delayed loading protocol, on the first placement of implant and a 3 months waiting period, and then the second surgery and placement of abutment, and again after 5 months the final impression and placement of final prosthesis at a 7-month time. Whereas immediate loading protocol, prior to the surgery, preparation of the surgical guide and individualized impression tray, and at the placement of implant, impression is taken and the preparation of the placement of a provisional prosthesis within 24 hours of implant surgery. And then again after 5 months, the impression and the final prosthesis at a time of 7 months from the surgery time. So these are the two different main protocols, that is a delayed loading two-stage protocol and the immediate loading protocol. Let us see the guidelines for immediate loading for completely edentulous fixed prosthesis. So these treatment plan guidelines should reflect methods to reduce stress and also microstrain and developing interface. So as we have already discussed, first is the surface area factor, under that comes the implant number. So 8 splendid implants or more are suggested for completely edentulous maxillary arch, and 6 splendid implants or more for mandible. So more implants are required if the density of the bone is less or if force factors are greater, like in case of parafunction. Then comes the implant size. 10 mm long and 4 mm wide implants are selected, and larger diameter implants are required in posterior regions of mouth. And if larger diameter is not possible, then bone augmentation procedures or greater implant number is suggested. Then next is the implant design, where high surface area implants, that are the implants with more threads and deeper threads, are required. And the implant surface condition, where hydroxyapatite coated implants are selected, especially in case of poor density bone types. Coming to the force factors, under that comes the implant position. So in a completely edentulous maxilla, anterior implants should be at least in the bilateral canine position, and posterior implants in first to second molar position for the largest AP dimension. Whereas when forces are greater, dentist should insert an additional implant between the canines, that is in the incisor region. Then in the mandible, the largest anterior posterior dimension possible should be used, and at least 3 implants, that is 1 in the anterior and 1 in each posterior regions, are necessary. Coming to occlusal load direction, so narrow occlusal table should be used and no posterior offset loads should be placed on transitional restorations in either arch, and the cemented transitional prosthesis uses a definitive cement like a polycarboxylate or a GIC rather than a temporary weaker cement. And whenever possible, long axis loads should be applied onto the implants. Then coming to the occlusal contacts, that is only anterior occlusal contacts in the transitional restoration. Then the patient related factors, that is a patient condition, that is parafunction, crown height and muscular dynamics, require more implant surface area. So parafunction, if it is severe, that may be a contraindication for immediate loading of completely edentulous patient. And coming to diet, patient should be advised to have a soft diet. Next, let us discuss about the NFIT concept, or non-functional immediate teeth concept, which was proposed by Misch. So this concept presents a similar approach to the immediate loading technique for a completely edentulous patient, but with two major exceptions. So in detail about NFIT concept, we will be discussing in our next session. So thank you everyone for watching my video. Please do like, share and subscribe to my channel if you are finding these videos useful. And if you have any queries, any topic that needs to be discussed or any feedbacks, you can comment below this video or you can mail me at this mail ID. So thank you all once again, and we'll meet in our next session.